Hello, I'm Cindy Perlin, the founder and CEO of the Alternative Pain Treatment Directory, and I'm here with Dr. Alex Kulick. Dr. Kulick has a practice in New York City where he specializes in helping people with chronic pain. And he's board certified in emergency medicine and internal medicine. He's been trained in quite a few techniques that are very innovative, and he's gone all the way to France at times to do it. So thank you, Dr. Kulick, for joining us here today. Can you tell us a little bit more about your background? I know you've been quite a few places and you know, a broad range of experience.
Sure. I began I did internal medicine, followed by 17 years as a ER chief, which basically honed diagnostic skills. That was the kind of great benefit of being an ER, along a multidisciplinary fashion, in the sense that you had to be able to diagnose both surgical and vascular and internal medicine and OBGYN, and really combine it all in one. During that time, I studied acupuncture and did a 2-year course for doctors in acupuncture here in New York City. When I sort of felt I had learned as much and taught as much as I could in the ER, I joined Dr. Woody Merrill, who opened up the Center for Integrative Medicine at Beth Israel here in New York, and had one of the first fellowships and actually departments. He had a full department in integrative medicine and was his partner for several years. And he pretty much introduced me to integrative medicine. And also introduced me to Alan Gaby, who's one of the big nutritional medical docs in the field. A lot of Dr. Bland, who's become, apparently functional medicine has taken off. 10 years ago, you never really saw it. Now it's all over the internet.
Can you talk a little bit about what integrative and functional medicine is? Because some people listening may not know what they are, what the difference between the two is.
Integrative medicine means that we combine techniques from all over. So we integrate both, not just Chinese and Western, but naturopathy, various French techniques, different Japanese techniques. So integrative is a very all-inclusive term.
Mm-hmm.
And a integrative doctor doesn't mean the same thing. So a integrative doc may do primarily hormones. They may do primarily nutrition. They may do a combination of Asian herbs and regular medicine. But integrative means that we're combining other medical traditions with Western medicine. So we don't abandon Western medicine, we just add to it. Functional medicine is very specifically the belief that the small intestine should be impermeable, meaning nothing really should pass through the wall of the small intestine except by intent of the body, meaning energy is expended to get that particle in. If there's damage to the gut wall, either through dysbiosis, meaning an imbalance of the good and bad bacteria, or from NSAIDs, aspirin, Motrin, alcohol, or food allergies, the gut wall becomes permeable, which means particles pass in that shouldn't be passing in and set off an inflammatory response in the blood, which can result in anything from skin conditions, allergy, or joint pain, eczema, a slew of inflammatory conditions, and we usually treat that with various, by first seeing if there is a food allergy, and if so, eliminating it. So celiac disease, which is an allergy to gluten, is something that damages the integrity of the small intestine, allows particles that are inflammatory to get into the bloodstream, and results in a whole slew of both arthritides and skin conditions. So a functional doctor will use a combination of various herbs, elimination of possibly toxic substances, look for food allergies, and then using a combination of herbs prepares the gut wall and will reduce that inflammatory response. So with Woody Merrill, I trained a lot in that. Bland is really kind of the forefather of it. I trained a lot with Alan Gaby, whose food allergies and really was kind of the father of nutritional medicine. When I moved on, I joined someone who did, an osteopath who did trigger points. And that's when I really began using, in combination with acupuncture, I used needles more.
So trigger point injections, you're talking about when you say trigger
The trigger
point.
point injections are, was first described by Janet Travell. She was John F. Kennedy's doctor. You remember he had PT 109, he had a bad back, and so she was one of her doctors, and she discovered that there were, if certain muscles spasmed, that it would radiate to other places. So for example, someone would come in and present as a sinusitis with mainly periorbital pain around the eye. And yet the muscle at the base of the skull would be in spasm. And if you found the point that caused the muscle to like fasciculate, if you found the trigger point, you would see the muscle tremble in a way, kind of a motion like that. And then you see a release of the muscle. When you release that muscle, the pain behind the eye would go away as well. And she had mapped out the entire body pretty much. You know, there's pain in the back. You can have a point in the back of the leg, and that will result in knee pain, for example. Nowhere near the knee, and yet if you release that muscle, the pain in the knee will resolve. So I began with trigger point, and then got very interested in something called mesotherapy. And mesotherapy, you have 3 layers to the skin. You have the epithelium, which is the most superficial layer of the skin. And that's what prevents bacteria from constantly infecting us. Next, you have a layer called the dermis, which is where all the blood supply is. And then finally, below that, you have fat. What the mesotherapists in France discovered was if you put a tiny drop of any type of medication between the epithelium and the dermis, meaning between the most superficial layer of the skin, right underneath that layer, the medicine would stay there 8 to 12 hours.
Wow.
So what this means is if you have pain in your thumb, normally, let's say you would take 800 milligrams of Motrin. All right, but the entire hand is only 5% of your body surface area. Your knuckle is, your entire thumb is 1%. And your knuckle is even a third of that. So instead of 800 milligrams, we said 5%, we would use 4 milligrams for the entire thumb. And we would use about a third of that, so about 1.5 milligrams. And they're very superficial injections. They're not deep injections. You don't even really want to draw blood because that would mean you're already into the second layer.
Dr. Kulick, can I just ask you to move your screen so I can see more of your face?
Sure.
Little more.
I never learned
No,
that.
the other way. The other way. Good. That's better. Okay.
Okay, so the idea would be using, instead of 800 milligrams, we'd be using less, about 1.33 milligram.
Mm-hmm.
They found that instead of with a deep injection, it would stay in the area for about an hour. By mouth, about the same. But by using this technique, it actually bathes it with kind of 1/800th of the dose for 8 hours. So it has a much more profound effect. And it's used on the Olympic teams, and it's a very common technique in France. In France and Russia and actually Brazil.
Mm-hmm.
So, and it can be used for muscle spasms. It can be used for joint pain. It can be used very well to stabilize without the side effects, stabilizing various neuropathies, which normally are incredibly hard to stabilize. You either need gamma globulin infusions, or you need very high doses of gabapentin and various other nerve stabilizers. Here, in general, we're using about, depending on the length, usually it's about 1/16 of the dose.
So are you using the same doses? Are you using something like gabapentin to inject?
So we'll use that medication, but we'll use it once a week as opposed to minimum daily. So say, let's say 800 milligrams of gabapentin, we'll be using about 1 milligram or 2 once a week.
And is that when you say using, injecting it?
Injecting.
Mm-hmm. And you're injecting it locally where the pain is?
You inject locally along the nerve path. And like I said, you inject very superficially. You just want to get through the epidermis. You don't even want to draw blood.
Mm-hmm.
When I do it on my brother, it actually tickles him. So I can't do it on him because he moves. He won't like stay put.
So what about somebody who, like someone with fibromyalgia who has pain all over? Is that
fibromyalgia is kind of very interesting. A couple of years ago, first they didn't really believe it existed.
right.
Then they believed it existed, and they made the diagnosis by pushing you in 10 spots. But what they discovered, and I spoke with a researcher in Boston, was let's backtrack. They were experimenting with a drug that used to be actually a party drug, like a club drug.
Mm-hmm.
And they found that it increased phase 3 sleep. And when they increased phase 3 sleep, people who had narcolepsy, it was basically a drug for narcolepsy.
Mm-hmm.
They found that by using this drug and increasing phase 3 sleep, the narcolepsy resolved. What they also found was that about 80% of people with fibromyalgia got much better as well.
Mm-hmm.
So the two ways of approaching it would either be functional medicine, something like fibromyalgia, but this drug Xyrem has almost no side effects, and it's out of your system in 4 hours. And I've actually used it on a number of patients with fibromyalgia and gotten great results where they feel 80, 90% better. So
Wow.
it's kind of hard to inject someone all over the body. So the two approaches really would be the functional medicine and herbs and decreasing inflammation.
Mhm,
And
mhm.
that has worked. Xyrem, but that's also for people willing to go through a algae elimination diet, which is not the easiest thing in the world, and follow a regime of herbs for quite a while. The Xyrem works extremely well, and like I said, is you can't even really detect it in your system 4 hours.
Mhm, mhm. So is that an off-label use, using it for fibromyalgia?
It's a off-label use of Xyrem, right? The
Okay.
main use is for narcolepsy, but there's been sort of extensive research in using it, and it's off-label the way gabapentin is.
Yeah.
You know what I mean? Like nothing is really on label for, say, bad neuropathies, except
Mhm.
they're
Yeah.
when they use all these anti-seizure drugs, they're all off-label. But increasing the phase 3 sleep with Xyrem and resolving the fibromyalgia, while not well known, is known to kind of well-educated neurologists and rheumatologists. They're aware that increasing that phase 3 sleep will give about 80% improvement.
Mhm.
That was,
Is that an expensive medication?
yeah, you have to go through a sleep study.
Mhm.
I mean, you have to do a sleep study to show the lack of phase 3 sleep. And at that point, it's approved by insurance. But if you're paying
So,
out of pocket for it, it would be expensive.
so is that something that if anybody with fibromyalgia went through a sleep study, would they show a problem with phase 3 sleep?
The answer is probably yes. It seems like the cause of fibro is the lack of phase 3 sleep. And it seems like if you can get the person, it's the reverse of what we thought. We thought fibromyalgia gave you insomnia and light sleep. It's the light sleep and not being able to go into that deep wave sleep that causes the fibromyalgia.
Mhm.
So if you can treat that, then if you can increase the person's slow wave sleep, the fibromyalgia pretty much resolves.
Now, is that the part of sleep that's dream sleep, REM sleep?
It's actually referred to as slow wave sleep. It's
Mhm.
deeper than REM. REM
Okay.
is the light. So you have phase 1, 2, and 3,
Mhm.
and they're characterized by different wave patterns.
Mhm.
The deepest, the third phase, is referred to as slow wave sleep. And it only has to be about 5-6% of your entire sleep cycle.
Really? Wow.
But people literally have 0%. And that's what results in if you have that, you know, well, the lack of slow wave sleep seems to be directly correlated with fibromyalgia.
Mhm. Yeah,
So,
that's a very tough condition.
yeah. And, not many people are aware of the Xyrem. That
Mhm.
actually began more, remember we were referring to integrative medicine. It was actually the integrative docs who knows the research earliest, and then it went more mainstream.
Yeah, that's something that I have not heard of, up to this point, and I've been researching chronic pain for quite a while, as well as experiencing it and helping people with it. That's a new one for me. So you also have some not well-known injection therapies that you use some other ones. You were talking about a nerve therapy that uses water.
Yeah, that one is actually, I find, the most successful of almost all these treatments.
Mhm.
You know, to get like a immediate relief trigger point is very helpful.
So what is it called?
Be reminded. Well, it's called nerve hydrodissection.
Mhm.
So dissection means surgically means when you sort of peel away an area to expose, let's say, you would dissect through a person, you know, let's say to get for gallbladder removal, in a
Mhm.
standard surgical thing. All right, so that's the meaning of dissection. Hydro means that we use sterile saline, we use water. And rather than a scalpel, we use a needle. So that pretty scene in your background, if it was real, and if you're watering it, you would, as you made the nozzle smaller, the water coming out would have more force.
Mhm.
So
Right.
farther, more force, you open up the nozzle, it would become a wider spread, right?
Right.
So when we inject through a syringe into a very thin needle, the force of the water becomes like our scalpel.
Mhm.
It has enough force to push tissues aside.
Mhm.
Now, what we use it for are nerve entrapments.
Mhm.
So, for example, I had a patient with low back pain. Was supposed to go for surgery. He had a very nice herniated disc at the level of L4, lumbar, fourth lumbar. But his pain was more sciatic, meaning that with L4, the pain should have been down the left thigh in front. I mean, or the right thigh, or it should have been down the anterior thigh, the front of the thigh. Sciatica, it should have been down the butt and the back of the leg. So when you look under ultrasound, you can see nerves, which you don't really see that well with MRI. CAT scan, you don't see it all. MRI, sometimes. But if you follow the trace, if we tracked that sciatic nerve, we saw it was trapped under the piriformis muscle. So one of the muscles that goes across your butt, you know, from hip to, basically from the hip to your sacrum. It's like a band across your buttock. The sciatic nerve dives underneath that muscle. If that muscle is in spasm, it will trap and duplicate sciatica. So with this gentleman, I just, under ultrasound, saw that the nerve was swollen where it was trapped, right before the piriformis muscle. And we just separated the muscle from the nerve, just with saline. Now, he had either fallen on his butt, you know, a couple of months before, was kind of very athletic, did a lot of yoga, and that nerve probably spasmed, and then when it's inflamed, scar tissue will form. So we just use the force of the saline to break up the scar tissue, separate the nerve from the muscle. And he came in for we did 2 treatments on him. He came in for the second one. When he came to me, he wasn't able to stand for 5 minutes. When he came back to see me, he walked across the Brooklyn Bridge and up 60 blocks to get to me. He's still my patient for other things, and that was 5 years ago. You know, and saves him a surgery that would not have worked. You know, they
Right.
would have surgery in '04. It wouldn't have worked. They would have sent him to a physical therapist. 6 months later, he would have been back to either that surgeon or another surgeon.
Yeah, I think that happens a lot, that people, they do MRIs, they see so-called, disc disease, and they assume it's the cause of the problem, and the problem really lies in the muscles and not in other soft tissue and not in the disc.
No, exactly. I had another patient with he had knee pain, and then he had a torn meniscus. He was also 55, 60, had been in karate his entire life. And I'm sure if I did an MRI on 100 people who were over the age of 50, 55, athletic, and at any time in their life, I'd find a torn meniscus. I mean, I had a torn meniscus 25 years ago. Now, at that time, they were not eager. Nowadays, they have laparoscopy. And they make $20,000, right? So they're pretty eager to fix your meniscus. Back then, they just inject you with steroid, and actually, it was 25 years ago, and I'm fine. But he had a torn meniscus, and kind of against my advice, went to a surgeon, had laparoscopy. Too much cartilage was taken out. Ended up with bone on bone. Had to go for a knee replacement, which got infected.
Wow.
It had to be removed. And they put kind of a false joint in with antibiotics for a couple of weeks. Then they remove that, and then they do the knee replacement all over again.
Wow.
And he came to me about a year later after this entire disaster and kind of went, the damn thing is I still have the same pain that I did before. Right. And when you looked under ultrasound, the fibular nerve, which is a nerve that branches off around the knee, it curves around the fibula and then dives between two muscles. And quite often that gets trapped there. So the normal diameter of that nerve would be about 8 centimeters. The diameter of his nerve was 27.
Wow.
So it was almost 3 times larger than it should be. So it was just trapped around the fibular nerve. Mm-hmm. When we did the same thing, just the hydrostatic force of the saline water. Saline, to be clear, is just water with 9% salt. So it's consistent with what you have in your body.
Yeah, we're made of a lot of saline, right? We're made of saline, basically.
We're made of saline.
Yeah.
So if it's, for people that don't know, I mean, if it's less saline, it can blow up red blood cells. You want to have the same salt content as you have in your body. So same thing, just by finding the nerve and using the ultrasound to guide it, to guide the needle. I just separated that nerve from the muscle and ligament where it was being trapped. And that was it. That was the end of that pain. So it's the nerve entrapment syndromes are very, very underdiagnosed because most people don't have ultrasounds in their office. Europe is kind of far ahead of us in this game. And if you don't know there could be a nerve entrapment, you don't know what to look for.
Yeah.
So a lot of the MSK ultrasound, MSK is the musculoskeletal ultrasound guys and women, they have the machine, but they don't have the training to find the nerves. They use it to guide needles into more, joints, knees, elbows, but they don't really know to use it directly to isolate, find the nerve, and also dissect the nerve away from the muscle or soft tissue that's trapping it. And I
It's
found
in,
that to be very successful.
yeah, that sounds really good. Are there many doctors in the US besides yourself who do this, or would people have to come all the way to New York if they were interested in this, or go to Paris, which might be more attractive to some people?
Well, there are probably like, oh, 15, 20.
Yeah, that's not a lot.
But, no, there are one or two in San Diego, West Coast. There's one in Jersey. But I don't think he does nerve, but one in Boston. There aren't many, but you don't have to come to New York City. There you have Sandy might teach the guy who taught me, who's sort of a cowboy, has really been into ultrasound from the very, very earliest years, and really is the most, I think, advanced in these nerve hydrosections and using ultrasound for more than just bony joints, basically.
Mhm.
Who's really specialized in nerve. He's actually in San Diego.
Mhm.
And
Yeah, I think that most doctors, conventionally trained doctors, don't really know anything about soft tissue. They know about joints and bones, but their knowledge seems to end there in terms of the body, in terms of
yeah, even these
generators.
peripheral nerve entrapments, even neurologists don't really know about it.
Mhm.
And if you can't consider it, if you don't know about it, you can't consider it in your diagnosis, right?
Yeah. So I would assume that that kind of nerve entrapment can be in the neck or the back or the buttocks or the arm,
It's
just
really
about any.
just anywhere. You know,
Sometimes would carpal tunnel syndrome sometimes be, or often be nerve entrapment?
carpal tunnel is always nerve entrapment. That's
So
actually
there's not a need
definition.
for surgery, that you can just do what you do.
Right, rather than be down for 6 weeks. The other thing with surgery is every time you do surgery, you develop scar tissue.
Right.
You develop scar tissue, you may end up in exactly the same position you were in before.
Right.
This is much more gentle.
Mhm.
So, let's say we're talking about, let's say, misdiagnosis. If you have pain raining down your arm, classically, what you say chronic pain a lot. What would you think most docs would say it was?
Probably a disc in your neck, right?
Right. And now they would do an MRI and they probably would find a disc in the neck. And now you'd have a fusion of the neck, right?
Right.
But just as often, it's actually nerve. The radial nerve can be trapped in the forearm, give the exact same presentation. The axillary nerve can give the exact same presentation. And you have a nerve in your neck, a plexus, that can also give the exact same presentation. All of which are easily accessible with a needle
Mm-hmm. Mm-hmm.
and carpal tunnel.
Mm-hmm.
And with carpal tunnel, the fascia that is compressing the nerve,
Mm-hmm.
through overuse has gotten built up too much, can easily be separated away from the nerve. There's an entrapment that goes to the thumb in what's called Guillaume's canal.
Mm-hmm.
There's the axillary nerve entrapment, which gives you pain in the entire arm. And basically, I've treated no one really I haven't treated anyone for pain going down the arms, what we would call cervical radiculopathy.
Mm-hmm.
In 10 years, I haven't treated anyone by sending them to the surgeon.
Mm-hmm. You've been able to treat
they've all
them
been,
with these injections.
yeah. They've
That's
all been,
great. That's great.
and these injections take, 15 minutes and you walk out.
Yeah. Yeah.
So, but yeah, they're all over. So you have, sag nerve in the butt. You have another one that gets trapped at the base of the butt
Mm-hmm.
and mimics sciatica.
Mm-hmm.
You have the pudendal nerve, which gives a lot of people perineal genital pain.
Mm-hmm.
Uh, I'm just thinking the most common, there's a nerve which is especially common in overweight, and if you sit a lot, you compress the nerve right below the groin.
Mm-hmm.
And it doesn't hurt you there, it hurts you in your hip.
Mm-hmm. Mm-hmm.
And with all these things, if you've been doing sports even when you're young, and if you're like over the age of 50, you're going to have some arthritic changes, right? So a surgeon takes a look and they go for surgery.
Yeah.
So the nerves can duplicate a lot of the pain.
Yeah. Yeah.
And since so few docs, like I said, the go-to here in the United States is MRI.
Mm-hmm.
You won't pick it up on MRI.
Right.
The go-to in Europe is ultrasound.
Really? Wow.
Which is why before they do x-rays, before they do anything, you're in the office, they have a ultrasound there, they know how to use it, and that's their go-to.
Yeah. So in Europe, how common is this injection therapy?
I'm sorry?
In Europe, how common is this injection therapy?
The nerve hydrodissection is much more common.
Very common though?
I would say at any of the major university hospitals, yeah.
Really? Oh, well, that's interesting. Yeah, we do practice medicine very differently in this country. I think it's one of the problems is it's much more profit driven. You know, a lot of people make a lot of money, especially hospitals and pharmaceutical companies over, real high tech medicine and surgery.
Well, they do make a lot, and those MRIs cost a lot. So you got to do a lot to make back your investment and make a
Right.
little die, right?
Yeah, yeah.
But,
So you do some work with stem cells.
yeah, I do PRP and STEM.
So
Stem
what's the difference between PRP, and tell people what it stands for, and stem cell?
All right. Well, we'll start with the kind of simplest. That is prolotherapy.
Mm-hmm.
So what most people don't realize is that inflammation is part of the healing process. And I'll explain what I mean by that. All right, prolotherapy is really just a mixture of water and dextrose, sugar.
Mm-hmm.
Because it has a different, I'm trying to avoid technical terms. When we discussed 9% saline, we were saying 9% water. We were also saying that there's the same amount of particles per milliliter, let's say. Hypoosmolar means you have less particles than the body does. Hyper means there are more particles in the water you're injecting than your body normally has.
Mm-hmm.
All right, so it could be 25 to usually about 25% more particles. What happens when you inject that into a very specific area, like a torn tendon, is it creates an inflammatory response. In this case, we call it osmotic shock. What happens is white blood cells first go into the area, and that's what creates the inflammation. But basically, it's a reflex on the part of the body to send the white blood cells in to kill anything that has damaged anywhere in the body. The next step is it causes stem cells to migrate into the area of damage. So let's say you cut your skin. First, it's going to get red and inflamed. That's going to be the white blood cells. But if I sew up that cut, I'm not creating new tissue. I'm just making sure your scar is nice and smooth, right? What's going on is the platelets go to that area. The platelets plug it up so you stop bleeding, but they also emit growth factors, and they also emit a signal for stem cells to migrate into the area and create new tissue. So stem cells can differentiate. They're primitive cells that can become bone, skin, ligament, tendon, muscle. Or at least the ones I'm referring to, the ones that kind of are in any fatty area.
So these are the person's own stem cells that are moving towards the area. It's not that you're injecting stem cells from some other source.
Right. You know, right now all I'm talking about is injecting sugar water.
Right. Okay.
And the body's response. All right, the next level would be platelet-rich plasma, and that means we're skipping one step. Right? You cut yourself. The white blood cells went in the area. Platelets then went to the area to stop the bleeding. And I said that the platelets now emit signals for stem cells to migrate from any fatty area of your body to the area that's been wounded. Okay. So PRP, we go directly to the platelets. We take your blood and we spin it down and we concentrate it about 8 to 10 times per milliliter. So if normally your blood per milliliter, let's say, has 1,000, we're going to concentrate it so that we're injecting 10 times that amount. So normally you really actually get about 200,000, and we're concentrating to 2 million platelets per whatever measurement you want to use per ounce, right? So usually from about, to give you an idea, from about 60 ounces of blood, we would normally get about 8 cc's of platelet-rich plasma. So we inject that into the area. So it does what it's supposed to do. It emits growth factors, but now 10 times that amount. And it emits signals for stem cells to migrate into the area and repair the tendon. The next step is...
So let me just stop you for a second and ask you, so is that just for tendons, or would that work for other tissues needing repair?
Works for muscle, tendon, bone. Is sort of iffy because it's hard to keep it in one spot. You know, if it's a encapsulated joint, which is where most, when tendons insert to bone, they're usually encapsulated, and the capsule will keep it in place. But if I were just to inject it into a clavicle, I'd have to figure out some way to make it stick there.
Mm-hmm.
And we played around with it, but we're not quite there in terms of. It would have to be like an encapsulated joint that was broken.
Mm-hmm. Mm-hmm.
So after PRP, so that's just we're going to get we start with prolotherapy, which created a osmotic shock and inflammatory response that brought in white blood cells and then platelets. We went to PRP, platelet-rich plasma, that by being hyper concentrated allows that much more growth factor and stem cells to migrate into the area. And then if there's really a bad tear, so sort of we're going from like small guns to bigger guns to the tank, or whatever.
Yeah.
And that is we harvest stem cells from your body, either from bone marrow or I mentioned before that adipose tissue, fat, is very rich in these cells. We harvest it from either, again, the bone marrow or adipose tissue.
Mm-hmm.
And we also spin that down and concentrate and only try to get rid of the red blood cells and white blood cells. So we're left only with these stem cells that they're a different weight. So different things, each time you spin, different things will be spun into the body. And then we take the extract that's left. Now, normally we combine that with PRP because the idea of the stem cell is we don't have to wait days for it to migrate to the injured area. We're injecting it in a high concentration where it's needed. But we still want the growth factors of the PRP. So normally we combine PRP, which is drawn from your blood, and stem cells, which is either taken out of the fattiest area we can find or your bone marrow. And is the most effective in terms of if the ligament and tendon is torn but not totally detached and ruptured, it's very successful.
Mm-hmm. Mm-hmm.
We use it also. PRP is the platelet-rich plasma is very successful for knee and meniscus.
I'm sorry, knee what?
It's very successful for knee and meniscus.
Oh, okay.
I mean,
So someone who has a torn meniscus, it would be very helpful.
Yeah, labrum in the shoulder,
Mm-hmm.
meniscus, it works ridiculously well.
Now, is it as good for, so my understanding is that if you're young and you have an athletic injury and you tear your meniscus, you have like a big tear. If you're older, you might have micro tears in your meniscus that are causing the problem. So does it matter which kind of meniscus tear you have?
No, actually, it's in young you can have a acute injury. Now, if the knee locks, then we can't use PRP.
If the knee what?
If the knee locks,
Locks.
meaning that there's a piece of the meniscus sticking up and jamming your knee.
Uh-huh.
So you, let's say, can't fully extend your knee,
Mm-hmm.
then you have to go in and you have to remove that piece that's getting, everything jammed up.
So when you say go in, you mean have surgery?
Yeah, for that you need surgery.
Mm-hmm.
Because what's literally happened is instead of it being flat, it's got fragments gumming up the work.
Mm-hmm.
So, but if it is not locked, whether it's a acute injury like in someone young, or what we call a degenerative tear, meaning wear and tear has kind of torn it. They're tears. It's not micro tears. They're tears.
Mm-hmm.
And someone who's 50, 60, 70, whatever. PRP will work on either.
Mm-hmm.
And again, I had a guy who he wanted me to fix his knee in time for ski season in the Alps, of all places. And we had to do him like 8 times because he was like I had like, I think in November, and he wanted to be skiing the Alps by January. But he, in fact, did his last treatment. He walked from Soho. You're a little familiar with Manhattan, slowly downtown Manhattan. Up to my place on 61st Street.
Mm-hmm. Mm-hmm.
And went on to go ahead and ski his Alps.
So he had, you said 8 treatments. What would be a typical number? And we're talking PRP now, or we're talking stem cell?
Yeah, that was PRP.
Oh, okay.
Stem cell we usually do 1 time.
Mm-hmm.
Well, we kind of prep the area with 1 PRP. Then we do stem, and then we do 1 more PRP. So it's really 3 injections.
Mm-hmm.
1 of them we do the stem.
Mm-hmm.
The other 2 are relatively fast injections. And stem cells, we usually give it a good 6 months to see results, and then decide whether another treatment is indicated, or more often than not, that's usually 1 treatment.
Mm-hmm. And where are we in terms of insurance being willing to reimburse any of these injections you're talking about?
Some very recently started covering PRP,
Mm-hmm.
but only a handful. I think.
Mm-hmm.
The only one I came across was the Actors Guild.
Oh, that's pretty. Covers a pretty small portion of the population.
Yeah.
Yeah, maybe in New York it's a large number, but
It's not a big part.
not.
So some of them, but generally insurance will not cover.
Mm-hmm.
Definitely won't cover stem cell.
Yeah.
Um,
They'd rather have you have a surgery, which is much more expensive.
Yeah, one of my patients recently, developed something called AVN, which is a little piece of your bone loses its blood supply.
Mm-hmm.
They're not entirely sure why, and sometimes it gets better on their own. But the treatment's either hip replacement or what they call coring, which is they go into the areas that are necrotic, that are dying because of lack of blood supply, and they drill it out. That surgery is $80,000.
Wow.
Now, conversely, the guy in Boston does the same and then injects stem cells into the area. And I don't know, it's not cheap, but I think he charges about $10,000
Mm-hmm.
compared to what insurance would get. He'll get $80,000 from insurance, and drilling, coring out that area by drilling and filling it with stem cells. I think actually you have a better chance at good recovery.
Mm-hmm. Yeah, I would think so.
They're in a way taking out the rotten area and hoping it stimulates blood supply, whereas injecting the PRP in the stem would stimulate the blood supply.
Mm-hmm. Mm-hmm. Yeah, there's a lot of ways that what insurance companies pay and don't pay for makes absolutely no sense, other than.
when I first went to Woody, Maryland, the integrative doctor that I trained with, I had a new patient who was new, like new onset diabetes. So not bad, like very early diabetes. And I was totally shocked that insurance wouldn't pay for a nutritionist.
Right.
They pay for glucophage, and they pay for them being on medication their entire life and developing all the complications of diabetes, but they wouldn't pay a lousy $100 for, him to see a nutritionist.
Yeah, it's insane. And it makes me think that there's some, shady relationship between the pharmaceutical companies and the health insurance companies, where they're linked in some mutually beneficial way. And that's why insurance would rather pay for medication than, teaching people
I
what
think
they
that,
be healthy.
no, I mean, I think there's that aspect, but the big thing is, I remember talking to well, rather than go into a whole long story, the minute the companies went on the stock exchange, the incentive is to raise premiums as much as they can, pay out as little as they can, because that's the way that the CEO and the shareholders make the most money, right?
Right, but paying out as little as you can would seem to indicate that they go to less expensive therapies.
No, you would think so, but that's not we already approved this. Their attitude is, for example, we already approved this $80,000 surgery. It's hard to pull back, but we're not going to approve PRP, okay, which is $5,000 until you absolutely force us to with top-notch research and basically twist our arms. It's kind of like, we already have a treatment for this, and that's corn. All right, well, that's $80,000. We could do stem cells, so it'd be 10,000, but to us, that makes it 90. Do you know what I mean? It's another thing we added.
Yeah.
So you're right, it doesn't make sense. You think, rather than a life supply of glucophage, seeing a nutritionist 2 or 3 times would make more sense, but they don't really run it that way.
Yeah. Well, this has been very interesting. I learned a lot that I didn't know. And
But I didn't bore you to death.
what's that?
I said I'm glad I didn't bore you to death.
No, it wasn't boring at all. And I appreciate you taking the time. And tell people how they can get in touch with you if they'd like to come to New York City and see you.
Oh, sure. It's Alexander Kulick, Kulick. Telephone number 212-867-1777.
Okay, and your office is on the Upper East Side, you said?
Yeah, it's 112 East 61st, and that's between Park and Lexington Avenue. And the person to speak with, other than myself, would be Heather, who's my manager.
Okay. And do you have a website?
Yeah, it's dralexanderkulick.com.
Okay. And also, Dr. Kulick is on the Alternative Pain Treatment Directory. He's one of our listed providers. And that you can find that website at paintreatmentdirectory.com. So if you forget all that other information, you can go to paintreatmentdirectory.com and look him up. So thank you again for speaking with me, and we'll talk again.
We actually have the Zoom to work.
Yeah. Yeah, so you have a great night. Thank you so much.
You too. Have a good night.